medical evacuation. I believe you know it by heart. I shall not be reciting it. And the flowchart of medical evacuation, which was inherited from the Soviet-style system. Naturally, with the start of the full-scale invasion, all of them have been revised, modified quite substantially, and have been harmonized with the NATO standards. But again, the war of the scale and gravity, like we are experiencing today in Europe, has never occurred in the European continent ever since the World War II. And the evacuation flowcharts had to be adapted respectively to the nature and scale of this armed conflict, which, among other features, is also manifesting... there's something wrong with this clicker. First of all, that would be inavailability of airborne evacuation, huge numbers of injured and injuries of different severity. So, as the result, we have this so-called long span of evacuation, long evacuation routes, which are used for transportation of the injured from the frontline hospitals to the safe area, skipping some of the elements of the conventional evacuation flow chart. This could be involving some of the elements of specialist care and also releasing the medical evacuation from the huge numbers of extremely severe cases that require massive resources, both in terms of human resources as well as medicines and equipment, which in most cases is not available. And there are four categories of such patients. One of them, particularly the predominant one, would be injuries via mine explosion with abdomen and both low extremities affected. Usually they require artificial ventilation support and special resuscitation vehicles to take them to the safe area. The second category would be patients with amputation without any abdominal injury, involving long-term care, and also care of tourniquet syndrome and with further prosthetic and orthotic care. Third category would be patients with some conditions which are not related to the warfare, nevertheless requiring long-term care and support. Here you can see a patient with acute myocardial infarction who was delivered to the Dnipro Cardio Center for stenting and coronarographic intervention. And the fourth category would be patients with extremely severe wounds who have pessimistic prognosis. But again, we have to engage with such patients to make sure that we can release the capacity for other patients. And in most cases, anesthesiologist or resuscitation specialist should escort such patients. And here we should observe the appropriate positioning of the patient and its fixation, particularly with the TBI, traumatic brain injuries, and then using the respective draining devices to make sure that the drainage takes place effectively, monitoring vital functions of patients and route, timely response and correction of any violations. Pain relief, remembering most of them have been put on anesthesia prior to evacuation, warming, and modification of the evacuation pathway and route. Remembering the time and distance to cover might be extensive enough, which in its turn might cause additional complications en route, starting with the bleeding. If it's superficial, that would be the best case scenario, because this is an internal abdominal hemorrhage. We can hardly spot it at the appropriate time. Then anesthetic problems and some kind of anaphylactic shock, which also might occur. All of that can and should be managed by the resuscitation professional escorting such patients, and not to forget the technical issues and discrepancies, such as breakdown of either medical equipment or the transportation vehicle. such evacuation is also quite energy consuming. As you can see, usually there is one provider per patient, and the number of such patients is huge. And naturally, the respective number of vehicles which are fully equipped with the medical appliances should be provided, not to mention the driver, security, fuel, and other consumables which might be required for the benefit of successful implementation of such an evacuation operation. And the number of such resources and operators has been included into the structure of the armed forces and now is complemented by the non-governmental sector, including the Hospitaliers, other civil society, and voluntary organizations which also contribute to such evacuations, particularly in the long-term evacuations. Dear Yulia, I terribly apologize, but you have just 1 minute left in your time slot. Okay, in that case, let me emphasize that timeliness and due caution should be observed, and this is very difficult to overestimate the contribution made by the volunteer organizations, because in most cases there's absolute lack of professional staff who could be shared from the conventional services to provide such operations. Thank you, God bless you, and thank you so much for your helpful